Dear friends, dear colleagues, it's a pleasure being with you today. First of all, I would like to thank Dr. Ismail Kocak and his team for inviting me to this wonderful meeting. I'll be talking about office versus operating room for potentially cancerous lesions of the vocal folds and recurrent laryngeal papillomatosis. But first, I would like to invite you all to the Asia Pacific Laryngology and Phoniatrics Congress, which will be held between April 8th to 11th in Istanbul, Turkey. We will be very pleased if you just scan the QR code here and be in touch with us. We are in a paradigm shift in laryngeal surgery. The epithelial lesions of the vocal folds that we will talk today, the potentially cancerous lesions and recurrent respiratory papillomatosis, were being treated in the office at the end of the 19th century, as you see here in one of Jacob Cohen's pictures. But then we had the opportunity to use the operating room as our gold standard for many decades because we had advanced techniques in anesthetic approaches and endotracheal intubation, and also advanced surgical technology by using surgical microscopes, surgical lasers, high power magnification. So we had the chance to use our both hands with enhanced precision in the operating room. But with the advances in the chip-on-tip flexible laryngoscopy systems and fiber lasers, office-based treatments were reintroduced beginning from the 2001. First, we had different papers read by pulse dye lasers and then KTP lasers, and today we are using blue lasers with high standards. Why does this question matter now, office versus OR? Because office-based laryngology offers a cost-effective and functionally compatible alternative for selected cases. And it will even be more widely implemented if the endoscopic and laser instrumentation were more affordable. So the core question today is, for which lesions, in which patients, does office treatment match the operating room? The wise idea may be to define the office as the first step. We may have three different options. We don't have any set international regulations for that, but the office that we mentioned may be a hospital outpatient clinic. So it is in the hospital, it's just an outpatient ENT room that is being used in the hospital. It may be a freestanding voice center, which most of us work nowadays, or it may be a basic ENT consulting room, which may be difficult to use for, or may be used for limited procedures only. But the first and second options are very nice to use the OR as a treatment facility as we are using operating room. And of course, in the office, we need to have the endoscopy platform. We need to have the laser systems that we will use. We need to have the equipments to monitor and to be able to provide safety of the patient and also safety of the clinician as well. The minimum stuff required for such an office procedure is the phoniatrician himself, a trained nurse or technician, and usually a third staff member is needed to be dealing with the lasers and also helping with the equipments. What does each setting offer? What do we have in the office? What do we have in the OR? In the operating room, we have the capacity to suspend the patient, and we can use the microlaryngoscope, and also we can use rigid or flexible endoscopes. The patient is under general anesthesia. We can use all equipments we want. We can use cold steel or we can use laser equipments. And of course, we have the privilege to respect the histological fundamental levels of the vocal fold. But in the office, we need a patient's cooperation instead of anesthesia, but we have an option to numb the tissue by local anesthesia, by lidocaine. We usually perform under flexible endoscopes. Of course, we can use rigid endoscopes for some purposes, for different approaches in office, but we usually use the flexible endoscope, and we have the fiber delivery laser systems. In the operating room, the idea is to respect the layered microstructure of the vocal folds. So we can use microflaps, incisions so close to the pathology and at the highest level possible, just subepithelial capacity to work. And of course, we can have an orientation, three-dimensional orientation to the specimen. But in the office, we can ablate the tissue But what we try to do mostly is to target the vascular layers of the vocal fold. So we target the vasculature of the pathology. We still preserve the layered microstructure, so we preserve the lamina propria. And of course, we can stage, we can make more staged approaches than the operating room as the patient is not under general anesthesia. Histopathologically, of course, having a histopathological example is difficult in the operating room, so we continue to believe that typically glottal papillomatosis and potentially cancerous lesions patients should not be treated by means of local anesthesia if you don't have a pathological diagnosis before, without a histopathological diagnosis and established pattern of recurrent disease. There are different options which are called as optical biopsy. Among them, we can talk about contact endoscopy or we can talk about OCT, but they are usually only available in the operating room. The other filtering options, the biological filters that we use like MBI, iScan, spectra, may be used in the office. They give us an idea about the vascular patterns of the vocal folds, and according to those vascular patterns, we usually have an idea if the pathology is a potentially cancerous lesion or if it is parallel with what we see as in papillomas. You can see an OCT picture here. The upper one shows a healthy 3-year-old vocal fold tissue. Here you see that the basement membrane is here, and we see the lamina propria. In the lower part, you see the basement membrane is pushed. The lamina propria is here, deep in the tissue. So it is just an epithelial hyperplasia, which is so similar for every papilloma patient because this is just an epithelial disease. If we can one day use this technology in the office, of course, we will have more options to use office more than the operating room. What we should discuss, of course, although these are epithelial lesions, we are dealing with a potentially cancerous lesion. We should think about the oncological principles as well. Of course, having a margin control, having the assessment of the depth of invasion, and the ability to completely excise the tissue and to have a specimen integrity are higher in the OR. So OR still is the gold standard for oncological approach of the potentially cancerous lesions. We usually see white or red lesions, as you can see here. It may be a leukoplakia, it may be a erythroleukoplakia or erythroplakia. They are usually at the superior and medial parts of the vocal folds, and they are usually on the muscular membranous vocal folds. And of course, as the vasculature of the lesion increases, as the redness of the lesion increases, we have a more potential to have a higher grade of dysplasia. And if the lesion is thickened and rough instead of being smooth and flat, and the risk of having a higher grade of dysplasia also increases. So how about the repeated procedures? Actually, operating room is usually for bulky lesions and to be able to create longer disease-free interval while making one surgery at single stage, a large, deep surgery, but at once you have a larger, longer disease-free interval. But in the office, the model is different. We have an option to use it with even smaller lesions that don't deserve to go to the operating room, but those smaller lesions can be treated repeatedly, so it prevents that bulk accumulation and it can decrease the need for going to the OR. So we can have repeated surgeries, frequent surgeries in office, but in the operating room, we can reserve it for larger diseases and for longer disease-free intervals. How about the budget? There are different studies that define the expenses that are needed and also that are paid by the patient. And the ratio is usually 4 to 5-fold difference between the operating room and the office. So office is 4 to 5-fold more convenient for the patient or for the social security companies. Of course, when you are talking about repeated interventions, we should think about the service radius. Does the patient's place of inhabitance, does the patient's need for travel change our idea or change our approach for an operating room or an office procedure? We don't have any vocal fold lesion specific data, but we have such data for head and neck cancer patients. So this may be an idea, and this may be one of the parameters that we are thinking about while dealing with office patients. But this may also be an option for increasing the number of office procedure institutions availability for the patients, because if the patients need to travel a lot for having such operating room surgeries, and if we can reach a local office that they can be treated frequently instead of traveling to larger cities for operating room, this may be an idea to increase the number of office availability of the offices that can treat the potentially cancerous lesions. How about multifocality? When we are dealing with patients in the office, we usually focus on one point. But as you see here at the left side, this patient was sent to me for glottal papillomatosis by one of my ENT colleagues. But when I have examined the patient, as you see here, in the nasopharynx and at the posterior part of the uvula, I can see the papillomas. So does the multifocality or does the dissemination of the disease change our approach for going to the operating room or the office? I think yes. I mean, because we have a limited time while dealing in the office, which is usually limited to 20 to 30 minutes maximum. But in the operating room, you have a high amount of time. The patient is already asleep, so you can deal with a multifocal disease better in the operating room. How about the different areas in the vocal folds or in the larynx, like anterior commissure, posterior glottis or arytenoid subglottic area, deep ventricle, the ventricular apex? This is also important because sometimes, as you know, we have problems to suspend the patients in the operating room to be able to see the anterior commissure or the region just below the anterior commissure. Here you see one of my patients that I'm trying to excise the papilloma microsurgically, both by cold steel and also with lasers, which is a very difficult to suspend patient for anterior commissure. This may be easier if I can just turn my flexible endoscope and use it in the office. But this may be, and again, a very nice question to debate because it has all pros and cons at both sides. Pediatric cases, of course, it is not possible to talk about dysplastic lesions. We don't usually see any dysplastic lesions in pediatric cases, but for the papilloma cases, there are frequent needs for surgeries in the pediatric cases, but it is difficult to use the office as the main intervention place because for especially younger pediatric cases, this is difficult to obtain the patient's cooperation. But for older pediatric cases, we can use the office as well. About patient safety, if you think about the failures to finish the intervention, or adverse reactions or complications, office and OR gives us the high amount of security. We have a very limited number of patients that needs to abort the procedure or that we see adverse reactions or complications. So we can easily say that office and OR are both safe while we are dealing with potentially cancerous lesions and papillomas. About patient experience in the operating room, we usually don't need to stay in the hospital for small phonomicrosurgeries like the ones we are talking today. And this is the same case for the office. They return to activity just in hours. So studies show us that patients that had office procedures, more than 90% of them are still okay to have another office procedures. And if they have the same options, they usually try to stay in the office. So they have a predilection to go to the office instead of going to the OR. The functional outcomes are usually the same in the OR and in the office. In the OR, of course, the settings are more convenient for us because the patient is asleep and we can use the precise steps that I have mentioned earlier. But in the office, we know the limitations of our procedures, but we also know that we can repeat the procedure when it's needed. predict recurrence, of course, there are many studies about this. If the patient is still actively smoking, if the patient is a male above 60 years, if the patient has still the capacity to use alcohol, if the lesions are multi-located or bilateral, multifocal lesions, if the vasculature is, the vascular patterns are type 4 or type 5 lesions, these patients are usually more prone to recurrence. So, of course, these are not the only options for papilloma cases. We should have at least a few words about the upcoming new treatment options for papilloma patients. We have one FDA-approved medication, which is called Papillomas now, and there are very perfect studies that shows that bevacizumab has the capacity to control the disease without surgical interventions. And of course, HPV vaccines, both for prevention and also for treatment, are so helpful for papilloma cases. So these will be the mostly discussed treatment options for papilloma cases instead of where to treat them. Thank you very much for your kind interest, and I would like to invite you all to the Asia Pacific Laryngology and Phoniatrics Congress once again, and I hope you have a wonderful advanced phonosurgery day. Thank you very much.